Welcome back to Bookfulness. This is episode 20 in our comprehensive deep dive through clinically oriented anatomy.
Hi there. Yeah, last time we really got into the weeds with the large intestine, the spleen, and the pancreas, how they all work together in the upper abdomen.
Absolutely. Today, we're shifting focus to, well, the powerhouse of metabolism, the liver. Our goal today is pretty ambitious. We want to really get a handle on its complex anatomy, trace that whole biliary system, the ducts, the gallbladder, and maybe most importantly for clinical practice, map out the hepatic portal venous system.
That portal system is key. It's like the body's central processing hub for almost everything absorbed from the gut before it hits the main circulation.
Exactly. This organ, it really demands our full attention, so let's dive in.
Okay, so the liver. First off, size. We're talking about the largest gland in the body. The only thing bigger really is the skin, if you count that as one massive organ.
It's truly huge. About 1,500 grams in an average adult. That's, what, 2.5% of body weight?
That's right, roughly 2.5%. What's fascinating is how much bigger it is proportionally in a fetus.
Oh yeah, how much bigger?
We're talking about 5% of total body weight in a mature fetus, double the adult proportion.
Wow. Why so big before birth?
Well, primarily because it has a massive extra job in utero. It's a major site of hematopoiesis making blood cells. That function largely shifts to the bone marrow later on, but prenatally, the liver is a blood factory. Super vital.
Got it. So after birth, it transitions more into that metabolic gatekeeper role we think of, processing almost everything from the GI tract.
Almost everything. Nearly all nutrients absorbed go straight to the liver via the portal vein. The big exception is dietary fat.
Right. Fats take a different route initially, don't they?
They do. Most fats get packaged into chylomicrons and absorbed into the lymphatic system first, the lacteals. They bypass the liver initially and enter the bloodstream later up near the neck. It sort of prevents the liver from being totally overwhelmed right after a fatty meal.
Makes sense. And beyond processing nutrients and storing glycogen for energy balance, the liver's other major job is producing bile.
Exactly. That yellowy brown, sometimes greenish fluid, essential stuff. It contains bile salts that act like detergents to emulsify fats in the duodenum. Break them into smaller droplets so enzymes can actually work on them.
And it makes a lot of it, right?
Oh, yeah. Constantly churning it out. Somewhere between half a liter and a full liter every single day. Non-stop production.
Okay, let's place this giant organ. We generally say right upper quadrant, but it's more specific than that.
It is. It fills most of the right upper quadrant, but it also extends across the epigastric region, sometimes quite a bit into the left upper quadrant too. Its top surface, the diaphragmatic surface, fits snugly right up against the underside of the diaphragm, follows its curve almost perfectly.
And then the underside, the visceral surface, that's where it bumps up against everything else.
That's the complex part. It faces down, back, and a bit to the left, and yeah, it's covered in impressions from its neighbors. You can often see marks from the stomach, the first part of the duodenum, the right colic flexure, the right kidney, the suprarenal gland. It's really packed in there.
It really molds itself to the space. Now let's talk about how it's held in place, or rather the folds of peritoneum connecting it, and specifically this bare area concept.
Right, so most of the liver is wrapped in that slippery visceral peritoneum. But there are reflections, folds, where the peritoneum leaves the liver surface to connect to the diaphragm or other structures. The most obvious one is the falciform ligament.
The one running down the front, separating the right and left anatomical lobes.
That's the one. It comes from the anterior abdominal wall. But as this ligament reaches the top and back of the liver, its two layers split apart.
Ah, and that's what creates the bare area.
Exactly. The layers diverge. The upper layer swings out to become the front part of the coronary ligament, and the lower layer forms the back part. In between them, there's this large, roughly triangular patch on the posterior aspect of the diaphragmatic surface that has no peritoneal covering at all. It's bare.
So it's directly touching the diaphragm there, just connective tissue in between.
Precisely. It's adhered directly to the diaphragm.
Why is that clinically important, and why does it matter if there's peritoneum there or not?
Couple of big reasons. First,
Yeah.
The inferior vena cava actually runs in a groove, or it's sometimes even embedded, right in this bare area as it passes up to the heart. Second, and maybe more critically for infection, is that lack of a peritoneal barrier.
Meaning things can spread more easily?
Yes. An infection below the diaphragm, like a subphrenic abscess near the bare area, could potentially track directly through the diaphragm into the chest cavity, cause a pleural effusion or even an empyema. It bypasses the usual compartmentalization the peritoneum provides.
That's a crucial vulnerability. Okay, let's shift from the outside coverings to the inside structure. For ages, anatomy focused on the four external lobes. Right, left, quadrate, caudate.
Yeah, based purely on surface landmarks like the falciform ligament, fissures, the portus hepatis. You've got the big right lobe, smaller left, and then the quadrate and caudate sort of tucked underneath near the hilum.
But you hear surgeons talk, and that division seems, well, almost irrelevant for what they actually do.
It largely is for practical purposes like resection. What really matters clinically is the functional division of the liver, and that's all about the internal plumbing.
Plumbing meaning the blood vessels and bile ducts.
Exactly. The functional division is defined by how the portal triad structures the hepatic artery branches, the portal vein branches, and the biliary ducts are distributed inside the liver.
So there's a functional right liver and a functional left liver. How are they divided?
They're divided by a plane, an imaginary line really, that runs roughly from the gallbladder fossa on the underside up towards the IVC groove on the back. This plane is often marked internally by the course of the middle hepatic vein. It's sometimes called Cantley's line.
And this division is based purely on which primary branches of the portal triad supply which territory.
Correct. Everything to the right of that plane gets its main supply from the right branches of the hepatic artery and portal vein and drains bile via the right hepatic duct. Everything to the left is supplied by the left branches and drains via the left hepatic duct.
Okay, this leads us to the really granular level, the 8 surgically resectable segments. The Kuhnau classification, segments 1 to 8?
Yes. This is the system surgeons use. It breaks the liver down into 8 independent functional units.
What makes them independent?
Each segment gets its own dedicated tertiary branch of the portal triad. Think of it like this. Segment V, for example, has its own specific branch of the hepatic artery, its own specific branch of the portal vein, and its own specific bile duct branch that serves only it. They run sort of centrally within the segment.
So if a surgeon needs to remove a tumor in segment V, they can take out just that segment without compromising the main supply or drainage of segment 4 or 6 next door.
That's the principle. Because the main inflow vessels and the bile outflow duct for each segment are specific to that segment. They're intrasegmental.
Okay, inflow and bile outflow are intrasegmental. What about the veins draining the blood out of the liver, the hepatic veins that go to the IVC?
And here's the crucial difference. The major hepatic veins, the right, middle, and left hepatic veins, are intersegmental. They run between the segments.
Wait, so the supply lines run in the middle of the territories, but the drains run in the borders between the territories.
Precisely. The middle hepatic vein, for instance, runs in that main plane, separating the functional right and left livers, draining parts of segments on both sides of the plane. The right hepatic vein runs in the plane separating the anterior and posterior sections of the right liver.
So when a surgeon is doing a segmentectomy, they're actually following the path of these large hepatic veins as their guide.
That's often the key landmark. By dissecting along the plane defined by an intersegmental hepatic vein, they can cleanly separate the vascular territory of the segment being removed from its neighbors, minimizing bleeding and preserving the function of the remaining liver tissue.
Wow. That internal map is just incredibly sophisticated. It's not about lobes at all. It's about these 8 vascular zones.
Okay, having mapped the liver's internal structure, let's trace the pathways for what goes in and what comes out, starting with the bile drainage system.
Right. So we mentioned the dual blood supply earlier. About 25% oxygenated blood from the hepatic artery proper and 75% nutrient-rich deoxygenated blood from the hepatic portal vein.
And these run together with the bile duct. Yes, they travel together within that free edge of the lesser omentum, the hepatoduodenal ligament. That's the classic portal triad structure you find entering the liver at the porta hepatis.
Okay, so bile gets made in the liver cells. Where does it go from there?
It collects in tiny bile canaliculi, which merge into larger ductules, then into lobular ducts, and eventually these all coalesce into the large right and left hepatic ducts, draining the functional right and left livers respectively.
And these 2 main ducts emerge from the liver.
Usually near the porta hepatis, and they almost immediately join together to form the common hepatic duct.
Okay, common hepatic duct. Then it heads downwards.
It descends for a short distance, and then it's usually joined by another duct coming in from the side.
The duct from the gallbladder.
Exactly. The cystic duct, draining the gallbladder, joins the common hepatic duct. And the duct formed by their union is the bile duct, sometimes called the common bile duct, but bile duct is sufficient.
I remember reading the length of this final bile duct can vary quite a bit.
It can, yeah. Anywhere from 5 to 15 centimeters. It just depends on how high or low that cystic duct junction occurs. If it joins high up near the liver, you get a long bile duct. If it joins low down near the duodenum, the bile duct itself is shorter.
But once formed, its path is pretty critical, isn't it? Especially where it runs behind the pancreas.
Extremely critical. It descends behind the first part of the duodenum, then it tucks into a groove on the posterior, the back surface of the head of the pancreas.
The head of the pancreas, that immediately makes you think about pancreatic cancer.
It should ring alarm bells, yes. Because they are so intimately related anatomically, a tumor growing in the head of the pancreas very often compresses or completely obstructs that bile duct quite early on.
And that causes?
That causes bile to back up. It can't get into the duodenum, so it backs up into the liver, then spills into the bloodstream, leading to jaundice, that yellowing of the skin and eyes, often one of the first signs.
Okay, so the bile duct continues down and eventually meets up with the main duct from the pancreas itself.
Correct. The bile duct usually joins the main pancreatic duct just before, or as they enter, the wall of the second part of the duodenum. They often form a little dilated common chamber called the hepatopancreatic ampulla, or ampulla of Vater.
And this ampulla opens into the duodenum.
Yes, through an opening called the major duodenal papilla. And the flow of both bile and pancreatic juice through this opening is controlled by a ring of smooth muscle, the sphincter of the hepatopancreatic ampulla, or sphincter of Oddi.
So when that sphincter is closed, maybe between meals, the bile produced by the liver can't get into the duodenum. Where does it go?
It backs up. It flows back up the bile duct, back up the common hepatic duct, and then takes a detour into the cystic duct and fills the gallbladder.
The storage tank. Let's talk about the gallbladder itself.
Okay, it's this small, sort of pear-shaped organ, usually greenish, nestled in a little hollow on the visceral surface of the liver. Anatomically, we talk about the rounded end, the fundus, which often peeks out from under the liver edge. Then the main body, which lies against the liver, colon, duodenum, and then it narrows down into the neck, which connects to the cystic duct. Sometimes there's a little outpouching near the neck called the infundibulum, or Hartmann's pouch.
And the cystic duct connecting it back to the main system, it's not just a simple tube, is it? It has that spiral fold inside.
Ah, the spiral fold, or spiral valve. It's a really neat feature. It's a fold of the internal mucosal lining that runs in a spiral down the length of the cystic duct, which is only about 3 or 4 centimeters long.
What's its purpose?
It actually does 2 important things. First, it helps keep the cystic duct patent, or open. So when that sphincter down to the duodenum is closed, bile can easily flow backwards into the gallbladder for storage and concentration. The fold prevents the duct walls from just collapsing shut.
Okay, keeps the filling pathway open. What's the second thing?
The second function is maybe even more clever. It provides a bit of resistance to outflow.
Resistance? How so?
Well, think about what happens if you suddenly increase pressure inside your abdomen, like if you cough or sneeze or strain really hard. That pressure gets transmitted to the gallbladder. Without the spiral fold, that sudden squeeze could potentially force a whole load of bile out passively, down the cystic duct and into the bile duct, when you don't actually need it for digestion.
Ah, so the fold acts like a gentle brake. It prevents accidental emptying just from pressure changes.
Exactly. It ensures that bile release is primarily driven by hormonal signals, like the hormone CCK making the gallbladder contract, and the sphincter relaxing, not just by random mechanical pressure spikes. It adds a layer of control and prevents, sudden uncontrolled bile dumping.
That's fascinating. A simple fold doing such a complex regulatory job. Okay, let's switch gears completely now. We've done the output, bile. Let's talk about the massive input system, the hepatic portal vein.
Right, the HPV. Carrying, as we said, about 75% of the blood flow to the liver. And crucially, this isn't oxygenated blood from the main circulation.
It's blood coming directly from the digestive organs, right?
Precisely. Its whole job is to collect venous blood from the stomach, the spleen, the pancreas, the small intestine, and the large intestine, basically the entire abdominal GI tract plus the spleen, and deliver it straight to the liver first.
Why first?
So the liver can process everything that's been absorbed. It metabolizes the nutrients, carbs, proteins, detoxifies harmful substances, alcohol, drugs, bacterial toxins, removes bacteria that might have slipped through the gut wall. It's the first pass, filter, and processing plant before that blood gets returned to the general circulation via the hepatic veins into the IVC.
So how is this huge collecting vein formed? Where does it start?
The main trunk of the hepatic portal vein typically forms behind the neck of the pancreas. It's created by the joining of 2 very large veins. The superior mesenteric vein, SMV.
Which drains the small intestine and the right side of the large intestine.
Correct. And the splenic vein, which comes from the spleen, but also picks up blood from parts of the stomach and pancreas along its way.
What about the vein draining the rest of the large intestine, the inferior mesenteric vein?
The IMV usually drains into the splenic vein shortly before the splenic vein joins the SMV to form the portal vein proper. So all that blood gets funneled together.
It's a massive confluence of drainage. Okay, so this portal system delivers blood to the liver's filtering mechanism. What happens if that filter, the liver itself, gets clogged up or damaged, say, from chronic liver disease?
Well, that's where things get dangerous. If the liver tissue becomes scarred and hardened, like in cirrhosis, or if there's a clot blocking the portal vein itself, the blood simply can't flow through the liver easily. Resistance goes way up.
So pressure builds up behind the blockage.
Exactly. The pressure rises throughout the entire portal venous system, the splenic vein, the mesenteric veins, all their tributaries. This condition is called portal hypertension.
And when the pressure gets too high, the blood has to find another way back to the heart, right? It tries to find escape routes.
It does. It forces open tiny, normally insignificant connections that exist between the portal venous system and the systemic venous system, the veins draining directly into the IVC or SVC. These are the portal systemic anastomoses, or porticoval anastomosis.
Or like collateral pathways, safety valves almost.
In a way, yes. But they weren't designed to handle this massive volume and pressure. So when they get forced open and engorged with blood due to portal hypertension, they become dilated, fragile, and prone to rupture. And this leads to some very specific, very serious clinical problems at distinct locations.
The source highlights 4 major sites where these connections become pathologically significant. We absolutely need to know these.
Definitely. These are classic signs of advanced liver disease.
Let's start with Site A, the esophagus. This sounds bad.
It is arguably the most immediately life-threatening. Down at the lower end of the esophagus, small submucosal veins that normally drain downwards into the left gastric vein, which is part of the portal system, connect with esophageal veins that drain upwards into the azygos system, which is systemic, draining to the SVC.
So when portal pressure is high,
blood is forced backwards up the left gastric vein and into these tiny esophageal veins. They swell up massively, becoming esophageal varices. These are like varicose veins, but inside the esophagus, just under the thin lining.
and the danger is rupture.
Exactly. They are thin-walled and under high pressure. Swallowing rough food, coughing, straining anything can cause them to burst, leading to catastrophic, often fatal, bleeding into the upper GI tract.
Okay, Site B, the rectum. This connects to hemorrhoids.
Yes. Around the anus and lower rectum, the superior rectal vein, draining upwards via the IMV into the portal system, anastomoses with the middle and inferior rectal veins, which drain sideways and downwards into the internal iliac veins and IVC systemic.
So portal hypertension can cause hemorrhoids.
It can, by causing these connections to engorge. However, and this is a really important point, the source makes the vast majority of common hemorrhoids people experience are not due to portal hypertension.
Ah, okay. Explain that distinction.
Most hemorrhoids are caused by local factors, straining during defecation, chronic constipation, pregnancy, which increase pressure in the rectal veins locally, causing them to bulge. While portal hypertension can cause hemorrhoids by backing up pressure through the superior rectal vein, it's much less common as the sole cause. You usually see hemorrhoids in portal hypertension alongside other signs like varices or cysts.
So finding hemorrhoids alone doesn't automatically mean the patient has portal hypertension.
Absolutely not. It's a common misconception. You need the bigger clinical picture. Relying on hemorrhoids as a key sign of portal hypertension is often misleading.
Got it. Crucial point. Okay, Site C, around the umbilicus, the belly button.
This one's visually striking. There are small veins, the paraumbilical veins, that run alongside the remnant of the umbilical vein in the falciform ligament. These connect the portal system near the liver to superficial veins in the anterior abdominal wall, like the epigastric veins, which drain systemically.
And when portal pressure is high here?
These connections engorge dramatically, forming visibly dilated, tortuous veins radiating outwards from the umbilicus across the abdomen. This is the classic caput medusae sign, named after the snake-haired Medusa from mythology.
You could actually see the collateral circulation on the skin.
You can, yeah. It's a very clear, though usually late, sign of severe portal hypertension.
And the last one, Site D, the retroperitoneal connections, these seem less obvious.
They're more diffuse. This happens where organs that started in the peritoneum but then got fused to the back wall, like parts of the colon, duodenum, pancreas, have their posterior surfaces directly touching the retroperitoneum.
The bare areas of those organs.
Exactly. Tiny veins draining these organs Portal tributaries like colic veins, splenic veins, can connect directly with small veins in the posterior abdominal wall itself. Systemic veins like lumbar veins draining to the IVC. It's not usually one big vessel, but a network of small connections that can open up as another collateral route back to the systemic circulation, bypassing the liver.
So 4 key escape routes: esophageal varices, dangerous bleeding; rectal varices, hemorrhoids but interpret with caution; caput menopus, visible sign; and retroperitoneal collaterals, diffuse backup. All trying to deal with that liver blockage.
Okay, let's bring this anatomy firmly into the clinical world. Given everything we've said about the liver size, its position, its structure, it sounds like it would be pretty vulnerable to injury.
Extremely vulnerable. Liver rupture is actually one of the most frequent serious injuries in blunt abdominal trauma, and car crashes, falls, direct blows.
Why is it so easily injured? Several reasons. It's large, so it's a big target. It's relatively fixed in the right upper quadrant, so it can't easily move out of the way of an impact force. And the liver tissue itself is quite friable, meaning it crumbles or tears easily upon impact. Plus, a sharp blow to the lower right ribs can cause a fractured rib to puncture right through the diaphragm and into the liver.
And given its blood supply, a rupture must mean massive bleeding.
Massive, life-threatening hemorrhage is the immediate danger. Remember, it gets about 25% of cardiac output. Controlling that bleeding is paramount. Historically, surgeons might have tried to resect, cut out the damaged part, but that often led to even more bleeding and high mortality.
So what's the approach now?
The focus now is much more on damage control. Packing the area tightly with surgical gauze to apply pressure, tamponade, is a common first step. Increasingly, interventional radiology plays a huge role. They can go in via catheters and selectively block the bleeding vessels, embolization, without major surgery. Resection is really a last resort if bleeding can't be controlled otherwise.
Okay, let's move from trauma to a more systemic issue: hepatomegaly, an enlarged liver. What causes the pain when the liver swells up?
It goes back to the venous drainage. The hepatic veins draining the liver and the IVC they drain into have no valves.
No valves, so pressure can back up easily.
Easily and directly. If you have increased pressure in the right side of the heart, say from congestive heart failure, that pressure gets transmitted backwards, right into the IVC, then into the hepatic veins, and floods the liver sinusoids. The liver basically gets engorged with blood and swells up quite rapidly.
And the pain comes from the capsule stretching.
Exactly. The liver is covered by a fairly tough, fibrous layer called Glisson's capsule. This capsule doesn't stretch easily, so when the liver swells quickly, the capsule gets stretched taut, and that's what causes the characteristic dull ache, or sometimes sharp pain, usually felt in the right upper quadrant or right hypochondrium.
The source mentions a possible link between this mechanism and that common side stitch pain some people get when running.
Yeah, it's an interesting, though still debated, theory about runner stitch, especially the right-sided ones. The idea is that during strenuous exercise, the increased cardiac output might cause some liver engorgement due to that back pressure effect. Combine that with the diaphragm moving vigorously up and down, jostling the slightly swollen liver.
And maybe irritating the capsule or the peritoneum covering it.
That's the hypothesis. Irritation of the capsule itself or the diaphragmatic peritoneum it touches could cause that sharp localized pain. Since the diaphragm's sensory nerve, the phrenic nerve, shares nerve roots with the shoulder area, C3, C4, C5, it could even explain why sometimes stitch pain is felt or referred up towards the right shoulder. Plausible mechanism, but likely not the only cause of stitch.
Fascinating connection, though. Okay, from acute swelling, let's consider the chronic, devastating disease: cirrhosis.
Cirrhosis is really the end stage of many chronic liver diseases, most commonly caused by chronic alcohol abuse, but also chronic viral hepatitis, B or C, or progressive fatty liver disease. It's a process where the normal liver cells, the hepatocytes, are progressively destroyed and replaced by fibrous scar tissue and abnormal regenerative nodules.
So the liver structure fundamentally changes.
Dramatically, it becomes hard, shrunken in late stages, and the surface often looks bumpy, the classic hobnail appearance. Microscopically, this fibrous tissue forms bands that disrupt the normal architecture surrounding the portal triads and central veins.
And how does the scarring lead to portal hypertension? We mentioned it earlier.
It's a direct mechanical effect. All that scar tissue constricts and compresses the tiny blood vessels within the liver, the sinusoids, the small portal vein branches, the hepatic vein tributaries. It creates a massive increase in resistance to blood flowing through the liver.
So the portal vein blood arriving from the gut hits this roadblock.
Exactly. It's like a massive traffic jam inside the liver. Blood backs up, Pressure skyrockets in the portal vein and all its tributaries upstream, and that is portal hypertension, driving all those complications like varices and ascites we discussed.
And the treatment options are limited then. Shunts or transplant?
For advanced cirrhosis with severe portal hypertension, yes. You either need to create a shunt to bypass the blocked liver, or if the liver function itself is failing completely, a liver transplant is the only definitive cure.
Cirrhosis also ties into cancer, specifically metastasis. The liver is a very common site for secondary cancers, isn't it? Especially from the gut.
Extremely common. It's all about the blood flow pattern. If a cancer starts in the colon, for example, and sheds cells into the local veins,
Those veins drain into the superior or inferior mesenteric vein.
which flow directly into the hepatic portal vein. So those cancer cells get carried straight to the liver. The liver's sinusoids then act like a filter, trapping these circulating tumor cells, which can then implant and grow into secondary tumors, or metastases. It's the first capillary bed encountered by blood draining most of the GI tract.
The source also mentioned a less obvious route from the right breast. How does that happen?
That's usually via lymphatic drainage, exploiting that bare area again. The lymph vessels draining the liver's bare area can connect with lymphatics in the diaphragm and even the posterior thoracic wall, since breast cancer often spreads via lymphatics.
It provides a potential backdoor route to the liver, bypassing the main systemic circulation.
Potentially, yes. It highlights again how that lack of peritoneal barrier in the bare area creates unique pathways for spread, both for infection and for cancer.
Okay, let's switch focus to the gallbladder and the ducts. Gallstones, cholelithiasis, incredibly common, made of crystallized bile components, right?
Yeah, cholesterol stones are the most common type in Western countries, but pigment stones can also form. They often sit harmlessly in the gallbladder for years. Problems arise when they move.
Where do they typically get stuck and cause symptoms?
Three main pinch points. One is the very distal end of the main bile duct, right before it enters the duodenum, where it narrows near the ampulla. Second is the cystic duct itself, it's narrow. And third is that little outpouching near the gallbladder neck, the Hartmann pouch, where stones can collect and then try to pass into the cystic duct.
If a stone blocks the cystic duct, stopping bile from getting out of the gallbladder, what happens?
Two main things. First, the patient gets biliary colic. That's intense, often wave-like pain caused by the gallbladder muscle spasming as it tries desperately to push the stone out against the blockage. Second, the trapped bile within the gallbladder can lead to inflammation, swelling, and often bacterial infection of the gallbladder wall that's cholecystitis. The gallbladder gets enlarged and tender.
And the pain pattern for gallstones is pretty classic, isn't it? Where does it typically start and end up?
It often starts as a vague, poorly localized ache in the epigastrium, the upper central abdomen. That's typical visceral pain from the foregut origin. But as the inflammation develops, in cholecystitis, and irritates the peritoneum overlying the gallbladder, the pain becomes sharper, more intense, and localizes to the right hypochondriac region, the right upper quadrant, often pinpointed near the tip of the ninth costal cartilage where it meets the edge of the rectus muscle.
Murphy's sign territory.
Exactly. And if that inflammation gets bad enough to irritate the diaphragm right above the gallbladder,
Then you get the referred pain.
you can, yes. Irritation of the central diaphragm is sensed by the phrenic nerve, C.5. Since those same nerve roots supply sensation to the skin over the shoulder, the patient might complain of pain radiating up to the right shoulder tip. It's a classic referred pain pattern.
When these stones cause recurrent problems, the gallbladder often needs to come out cholecystectomy. Why is knowing the detailed anatomy of the ducts and arteries so critical during the surgery?
It's absolutely paramount because the risk of injuring the main bile duct or the common hepatic duct is significant and devastating. The surgeon must correctly identify and safely clip or ligate only the cystic duct and the cystic artery.
But the anatomy isn't always straightforward, right? There are variations.
Lots of variations. The cystic duct might join the common hepatic duct very low down, running parallel to it for a long way, making it easy to mistake one for the other. Or it might join very high up near the liver. It might spiral around the common hepatic ducts before joining. Any misidentification can lead to accidentally clamping or cutting the main duct needed for bile drainage from the liver.
That sounds like a surgical nightmare.
It is. It causes immediate jaundice post-op and requires complex reconstructive surgery. Similarly, the cystic artery, which supplies the gallbladder, needs to be carefully found and ligated.
Where does the cystic artery usually come from?
Typically, it arises from the right hepatic artery within a small triangular space called the cystohepatic triangle, or Callot's triangle. This triangle is roughly bounded by the cystic duct, the common hepatic duct, and the edge of the liver. But again, variations in the origin and course of the cystic artery are common, so the surgeon has to dissect carefully and be certain before applying any clips.
So, given these variations and risks, how do doctors visualize this anatomy beforehand?
The gold standard for non-invasive imaging of the bile ducts is MRCP, magnetic resonance cholangiopancreatography. It uses MRI sequences that highlight fluid, so the bile itself acts as a contrast agent, giving really detailed pictures of the ducts, showing stones, strictures, or dilation, without needing injections or scopes.
What about ERCP, endoscopic retrograde cholangiopancreatography? Is that still used?
Yes, but ERCP has largely shifted from being primarily diagnostic to being primarily therapeutic or interventional. It's invasive, requiring an endoscope down into the duodenum to inject contrast up into the ducts.
So you'd use it if you needed to do something.
Exactly. During ERCP, the endoscopist can actually remove stones from the bile duct using baskets or balloons. They can take biopsies of suspicious areas, or they can place stents across blockages caused by stones or tumors to restore bile flow. So MRCP maps it out, ERCP fixes it, generally speaking.
Okay, one last clinical area. Back to severe portal hypertension from cirrhosis. If the pressure is dangerously high, threatening variceal bleeding, you need to reduce it. You mentioned shunts earlier.
Yes, portosystemic shunts. The idea is to create an artificial, low-resistance bypass channel between the high-pressure portal system and the low-pressure systemic venous system, allowing blood to bypass the blocked liver.
And the common way to do this now is the TIPS procedure.
Correct. TIPS stands for transjugular intrahepatic portosystemic shunt. It's usually done by interventional radiologists, not open surgery.
How does it work? Transjugular means through the jugular vein in the neck.
That's right. They insert a catheter into the internal jugular vein, guide it down through the SVC, right, atrium, IVC, and then into one of the hepatic veins, which drain the liver into the IVC.
Okay, so they're inside a hepatic vein within the liver. Then what?
Then, using imaging guidance, they push a special needle through the wall of the hepatic vein and through a chunk of liver tissue directly into a nearby large branch of the portal vein, which is carrying the high-pressure blood.
They create a tunnel right through the liver parenchyma connecting the two systems.
Precisely. And once that track is created, they deploy a metal stent to keep the tunnel open permanently. So now, blood flowing into the portal vein has an easy, low-resistance escape route directly into the hepatic vein, bypassing the congested sinusoids, and flows out into the IVC. Pressure in the portal system drops significantly.
It's basically replumbing the liver's venous system from the inside out. Amazing application of anatomy.
It really is. It directly tackles the high pressure that causes the bleeding and fluid accumulation, all based on understanding those pressure gradients and vascular pathways. ### next Sinatra.
Well, that was certainly a deep dive. We've covered a huge amount today, from the sheer scale and internal functional segments of the liver,
Right down to the microanatomy of the spiral fold in the cystic duct.
and then mapping out that incredibly vital hepatic portal system, its formation, and especially those critical collateral pathways that open up in portal hypertension.
We really saw how interconnected everything is, how disease in the liver parenchyma, like cirrhosis, manifests with problems far away in the esophagus, the abdominal wall, the rectum, all because of that pressure back up in the portal vein.
Absolutely. So next time on Bookfulness, we're moving posteriorly. We'll be exploring the posterior abdominal wall itself and the major organs nestled back there in the retroperitoneal space.
That means we'll be covering the kidneys, the ureters carrying urine down to the bladder, and the suprarenal or adrenal glands sitting on top of the kidneys. We'll also look at the muscles forming the back wall, like psoas major and quadratus lumborum.
And we'll finish up that session with a look at the complex web of nerves supplying the abdomen. So definitely another packed session.
Looking forward to it.
Before we go, here's a final thought to connect today's discussion. They can potentially plan a simultaneous liver resection, removing those specific high-risk segments along with the primary colon tumor, even if metastases aren't visible yet.
Exactly. It moves from reactive treatment to proactive, anatomically guided resection based on predictable patterns of spread. Knowing that venous map allows for potentially curative surgery that wouldn't be possible otherwise, it really underscores that anatomy isn't just structure, it's destiny in a way, for how things move through the body.
Anatomy as destiny. A powerful thought to end on. Thanks for listening to Bookfulness.